is Roxanne Morales. I'm a nurse practitioner student with the University of Texas at Arlington. I'm going to be doing a full head to toe assessment on you. Is that okay?
Yes.
Could you state your name and birth date for me?
Eric Wagner, March 6, 1980.
Do you know where we're at right now?
Yes, we're at my home.
Okay. Who is our current president?
Barack Obama.
Good. Patient is well groomed. He is alert, oriented times 4. How would you say your mood is right now?
It's fine.
States his mood is fine, which matches his affect and it's appropriate to the situation. I'm going to wash my hands and we're going to start this, okay? All right. I'm going to inspect the patient's skin. Skin is pink, healthy, no lesions are noted. Turgor is brisk. I'm going to check his nail beds and capillary refill. Cap refill is less than 2 seconds. Nails are short and well groomed. The nails adhere to the nail beds well. Going to check for the angle of the nail to check for any clubbing. Can you get your hands like this for me, please? And do pinky to pinky. Angles of the nail is approximately 160, and there is no clubbing noted. I'm going to assess his head. Head is round, normocephalic. The hair is evenly distributed over the head. I'm going to, no infestations are noted. I'm going to inspect his scalp. Scalp is clean, no infestations noted, no lesions noted. I'm going to palpate the head. No masses or felts, or is that tender?
No.
Patient report says the head is non-tender. I'm going to assess the facial. The face is symmetrical. There's neck is symmetrical. There's no thyroid megaly noted. Trachea is midline. I'm going to palpate the tracheal cartilage. If you can put your chin here, you swallow for me. Good. This way. Swallow for me. Good. The thyroid is palpable. Thyroid cartilage moves up when patient swallows. No masses or lesions noted. I'm going to palpate the carotid arteries. Carotid arteries are palpable. 1 plus. I'm going to listen over the thyroid for bruits bilaterally and over the carotids bilaterally. No thrills are noted. I'm going to palpate the lymph nodes starting at the occipital lymph nodes. We have the pre-auricular, post-auricular bilaterally, submandibular, tonsillar, submental, posterior cervical chain, anterior cervical chain. Can you shrug your shoulders for me? Supraclavicular. Don gloves and uncheck the axillary and the epitrochlear lymph nodes. Does any of that hurt, sir? Was any of that tender?
No.
All lymph nodes are non-palpable and non-tender. I'm going to assess the patient's eyes now. All right, the patient's eyes are symmetrical. The eyebrows are evenly proportioned over the eyes. There's no ptosis noted. Eyelids, eyelashes are over the eyelids well. I'm going to press on your eyeballs. Is that okay?
Sure.
Press the eyeballs. Is there any pain there?
No.
Good. Eyeballs are firm. Can you open your eyes for me? Good, thank you. Conjunctiva is clear, sclera is white, irises are blue. Lacrimal apparatus is soft with no exudate noted. Did it hurt when I was palpating around there? Patient denies any pain on palpation of the lacrimal apparatuses. I'm going to palpate The frontal and maxillary sinuses bilaterally. Any tenderness?
No.
Patient denies any tenderness of the frontal and maxillary sinuses. I'm going to now check the patient's vision using a Snellen chart. Snellen chart is used for far vision. It's placed 20 feet away. The patient reads the smallest line that he's able to, covering one eye and then the other, and then having both eyes open with and without correction. The second eye screening is a Rosenbaum chart, and that is kept at about 14 centimeters away from the face. Patient also reads the smallest line that they're able to with the left eye and with the right eye, both uncovered with and without correction. For the remainder of the assessment, we're going to assume that the patient's vision is 20/20. I'm going to check for pupillary response using my pen light for direct and consensual. I have direct and consensual constriction of the left and the right. I have direct and consensual of the right and the left eye. I'm going to check for accommodation. I'm going to have you look at my pen light, sir, and I'm just going to follow it in. Pupils accommodate. Pupils are equally reactive to light and accommodation. I'm going to do a uncover chest to check for nystagmus. You look directly behind me. No nystagmus noted. No nystagmus noted. I'm going to check for extraocular movement in each of the 6 cardinal fields. Have you look at my pen light and just follow my pen light. You don't move your head, please. Extraocular movements are intact. I'm going to perform an exam with the ophthalmoscope. Going right eye to right eye, I'm going to find the red light reflex, and then move in. The lens is round, edges are well approximated, there's no AV nicking and no hemorrhaging noted. I'm going to go left eye to left eye, find the red light reflex. Red light reflex is found, move in. Lens is round, symmetrical, edges are well approximated, no AV nicking, and no hemorrhaging noted. I'm going to assess the patient's nose now. Can you cover one nose and inhale? And one nostril and inhale, please. Thank you. Other nostril and inhale, please. Okay, nostrils, nares are patent. Does this hurt any?
No.
Denies any tenderness on palpation. No masses or lesions noted. I'm going to look inside the nares. While bracing the patient, look inside. Turbinate is pink and moist, no polyps noted. Turbinate is pink and moist, no polyps noted. Septum is deviated. Okay, I'm going to check the patient's mouth now. The lips are symmetrical, pink and moist. No lesions are noted. I'm going to have the patient open his mouth. I'm going to inspect the mouth. Tongue is pink and moist. No lesions are noted. Frenulum is intact. The bottom of the mouth is pink and moist with no lesions. Buccal mucosa is pink and moist with no lesions. I'm going to count his teeth now. 32 teeth, no caries, good dentation. Gums are pink and moist with no lesions or bleeding. Can you stick out your tongue and say ah for me? Tonsils are +1, uvula rises with phonation. We're going to say that the gag reflex is intact.
Thank you.
we're going to check the patient's ears now. I'm going to palpate the pinna. External canal is pink, no erythema, no exudate noted. Does that hurt at all when I palpate?
Negative.
Patient denies any pain on palpation. I'm going to look into the inner ear with the otoscope. I'm going to brace against the patient's cheek for his safety. Pull the pinna up and back. The internal canal is pink with no exudate, no erythema. The bony prominences are present. Tympanic membrane is pearly gray with no bulging. And the cone of light is at 7 to the left. I'm going to do the same with the left ear. I'm sorry, the cone of light was at 5 on the right ear. Excuse me. I'm going to do the same on the left ear, bracing against, pulling the pinna up and back. The internal canal is pink with no erythema, no exudate, bony prominences, bony landmarks are visible. Tympanic membrane is visible. It is a pearly gray. Cone of light is at 7 p.m. No bulging noted. Okay. I'm going to conduct hearing tests on the patient with the whisper test at first. I'm going to have the patient occlude one ear, and I'm going to whisper a 2-syllable word behind him and see if he can hear it.
Apple pie. Baseball.
Hearing is intact, as evidenced by the whisper test, patient being able to repeat apple pie and baseball. I'm going to do a Renee test now, and that tests air and bone conduction. You will use a tuning fork. You're going to strike the tuning fork and place it on the top of the patient's head and ask the patient if they can hear it better in the left or the right or in the middle and when it stops.
In the middle. Stop.
The patient has normal hearing conduction. The Weber exam is also using the tuning fork. You're going to strike the tuning fork, put it on a bony prominence, ask the patient when he stops hearing this.
Stop.
And then move it perpendicular in front of the ear to test air conduction. Ask the patient to tell you when it stops.
Stops.
Good. Do that for both ears. Tell me when it stops.
Okay.
Perpendicular in front of the ear to test air conduction. Air conduction.
Okay.
Good. Air conduction should be greater than bone conduction. Okay. I'm going to ask the patient to remove his shirt now. I'm going to check the chest for symmetrical. It is symmetrical. The respirations are even and unlabored. I'm going to palpate all the lung fields. I'm sorry, I'm going to percuss all the lung fields. Thank you. That was anterior, now posteriorly. Percussion to the lung fields are resonant. Going to auscultate all the lung fields now. Deep breath in and out. Just in and out. Sorry.
Okay. Sorry.
Good. All lung fields are clear bilaterally. No adventitious sounds are noted. I'm now going to check for tactile firmitus. This is done by placing your hands anteriorly and posteriorly with the palms, asking the patient to repeat a number like 99, checking for vibrations. 99?
99.
Tactile firmitus is felt. If it's not, usually the patient might have some areas of consolidation where it's not felt. All right, I'm going to move on to the cardiovascular system. I'm going to palpate the pericardium and the apical pulse for 1 minute. I'm going to auscultate with the diaphragm. Second intercostal space, right clavicular line, aortic valve. S2 is greater than S1. Second intercostal space, left sternal border, pulmonary valve. S2 is greater than S1. Third intercostal space, left sternal border, Erb's point. S1 is equal to S2. Fourth intercostal border, fourth intercostal space, left sternal border, tricuspid valve. S1 is greater than S2. And fifth intercostal space, left midclavicular line, mitral valve. S1 is greater than S2. You would also auscultate the apical pulse for 1 minute. Patient's apical pulse is 70, regular. No murmurs are heard, no splitting is heard. You would auscultate with the bell to hear low-pitched sounds and with the diaphragm to hear high-pitched sounds. Okay. Now we're going to, the cardiovascular assessment needs to be done in 3 positions: sitting, supine, and left lateral recumbent. I'm going to move, check all the pulses now. Bilaterally, the temporal, it's regular, +2, carotid, regular, +2, brachial, regular, +2, radial is regular, +2, post-tibial is regular, +2, and dorsalis pedis is regular and +2. Gonna move on to the abdominal assessment now and have the patient lie back. Going to assess the stomach. Stomach is symmetrical. Patient does have some bruising to the left lower outer quadrant and a healing incision, low transverse from hip to hip, as reported from a recent abdominoplasty. I'm going to auscultate the bowel. All 4 quadrants and the epigastric region. Bowel sounds are positive. I'm going to percuss. Tympany should be heard. And then we're going to ask the patient if he has any pain on light palpation. Any pain on light palpation?
Negative.
And then on deep palpation. Any pain on deep palpation? No.
Negative.
Patient denies any palpation, any tenderness on deep and light palpation. No masses were felt. I'm going to palpate and measure the liver now, starting at the umbilicus. I'm going to percuss from when I hear tympani to when I hear dullness. Right here, start from the bottom. Dullness to tympani. Going to measure between, which is about 8 centimeters, and normal is 8 to 12. So the liver is within normal size. Going to percuss the spleen from the 6th to 10th intercostal space. Can I have you sit up, please? Thank you, sir. Gonna attest CVA tenderness. Have any pain there? Okay. I forgot one part of the patient's assessment on the abdominal. We would be checking for Murphy sign. Murphy sign is usually done when you suspect problems with the gallbladder. You ask the patient to exhale, press down, and then ask the patient to inhale. And if the patient catches their breath, that's a positive Murphy sign, usually indicative of acute cholelithiasis. All right, sit up for me, please. Put your shirt back on. Thank you, sir. Okay, I'm going to assess the patient's musculoskeletal system now. I'm going to have the patient stand up for me. Patient straight, erect, able to hold his own posture. Posture's good. I'm going to assess your gait, sir. Assess the gait. Gait is steady, independent. I'm going to check for scoliosis. The scoliosis screen, I'm going to ask the patient to bend over. I'm so sorry. Bend over and touch his toes, filling up the spine, the hips, scapula, and shoulders are congruent, so the scoliosis screen is negative. I'm going to assess the Romberg for patient's balance. Have the patient stand with feet together. You're going to gently push the patient. Be ready to brace in case he does have problems with balance. Patient has a negative Romberg. He is able to balance himself. All right, you have a seat for me. We are going to do active musculoskeletal, active and passive range of motion now. Do active and passive range of motion on the cervical spine. I want you to look down, extend your neck, hyperextend, shoulder to shoulder, and internal rotation. Good. I'm going to do that for you now. I'm going to go down to your chest, back, shoulder to shoulder, rotation. Patient has full active and passive range of motion to the cervical spine. Going to move on to the shoulders now. Going to assess the shoulders and have the patient move his arms. Put his arms far back as possible as he can and up above his head. Good. I'm going to do that for you now. Behind your back and up above your head. Good. Patient has full range of motion and an active and passive range of motion to his shoulders. Going to do the elbows. We're going to go flex in, abduction, and abduction. In, out, abduction, abduction. Patient has full range, passive and active range of motion to the elbows. Let's do the same thing for the wrists. Dorsiflexion, flexion, outward, inward, lateral motion. Dorsiflexion, up, adduction, abduction, rotation. Our patient has active passive range of motion to his wrist. Do the fingers now. Try to pull your fingers apart. Good. Now I'm going to try to push your fingers apart. Good. I'm going to do that. Patient has active and passive range of motion, full active and passive range of motion to his fingers. I'm going to do the, check the knees now for active and passive range of motion. The knee is flexed to 160. Back. I want you to add up and add up the knee. Good. Now do the same with your left. Good. Now I'm going to do it for you. Good. Patient has full active and passive range of motions to the knee. We're going to do the ankles next. Then flex. What's flexion? Adduction. Abduction. Okay, I'm going to do this for you now. Patient has full active and passive range of motion to the ankles. I'm going to do the hips now. I'm going to ask the patient to lay back. Adduction, abduction, adduction. Can you do that for yourself now? Patient has full active and passive range of motion to his hips. I'm going to do the anterior drawer test now to check for problems with the anterior cruciate ligament. The anterior drawer test consists of patient lying supine. The hip is going to be flexed at 45 degrees. The knee is going to be flexed at 90. Going to make sure the hamstrings are nice and relaxed. Bracing the patient's foot, actually by sitting on them. You're going to brace the patient's foot and you're going to pull behind the knee upwards. If the patient has more than a 5 millimeter movement, it is positive for an anterior cruciate ligament problem. Also going to do the same on the other hip. This is going to be a little awkward. Can you turn that way? Thank you. Yeah, that'll work. So, same thing, have the hip flexed 45 degrees. And, no, you're good right there. Knee at 90, sitting on the foot, bracing it. Pull up, no movement noted when the knee is moved. So, ACLs are okay. Okay. I'm going to have you sit up now. I'm going to check the patient's cranial nerves now. Do you have any problems distinguishing smells? No problems. Cranial nerve 1, sensory, olfactory is intact as evidenced by patient stating that he has no problems distinguishing smells. Cranial nerve 2 is the optic nerve, which is intact as evidenced by the patient having 20/20 vision on the Rosenbaum chart. Cranial nerve 3 is optic nerve and it's sensory and motor. That is intact as evidenced, cranial nerve 5. Cranial nerve 5 is sensory motor and it's trigeminal. I'm going to ask the patient to clench his teeth. Clench your teeth. Good. And ask the patient to be able to distinguish against soft and dull, which I will do assess in just a bit. We're going to say that patient's cranial nerve 5, sensory motor, trigeminal is intact. Cranial nerve 7 is a sensory motor. This is tested by asking the patient to make various faces at you. Can you smile at me? Can you puff out your cheeks? Blow a whistle? All right. Are you able to distinguish sweet and sour?
Yeah.
Sweet and salty, excuse me.
Yeah.
Okay. So cranial nerve 7 is intact, as patient being able to make various faces and being able to differentiate taste between sweet and salty. Cranial nerve 8 is the sensory and is acoustic. This was intact as evidenced by the patient being able to do the whisper test. Cranial nerve 9 and 10 is a sensory motor and it's a glossopharyngeal. And that was evidenced by a patient having no hoarseness and the uvula rising on phonation. Okay. Cranial nerve. 11 is the spinal accessory nerve. It's motor. You're going to ask the patient to shrug his shoulders. Good. Sternal-mastoid, patient's intact. Cranial nerve 12 is the hypoglossal. It is motor. It's tongue movements. You ask the patient to stick out his tongue. Move it from side to side, up and down, and that is intact as well. We're going to check the patient's coordination. We're going to be doing your hands to your thighs. You're going to do palm down, palm up, palm down, palm up. Faster. Good. Coordination is superb. We're going to do the finger to nose test also. Have the patient close his eyes, have his hands raised out, and touch the nose with each arm. Faster. Coordination is intact. We're going to check between his sensation, whether or not the patient can tell the difference between soft, sharp, and dull. You want to orient the patient to what the sensations are going to feel like. Close your eyes. This is sharp. This is dull. And that's soft. Okay? So you're going to ask the patient, where do you feel that and what is it?
Soft on my face.
Okay.
Sharp on my arm.
Which arm?
Right.
Okay.
Yeah, right. Dull on my left.
Good.
Left leg.
Yes. Okay, now we're going to check for vibration using the tuning fork. You want to put this on a bony prominence and ask the patient whether or not he can feel the vibration. So we're going to do it on the elbow. Can you feel that?
Yes.
Good. And tell me where you feel this now.
On my left ankle.
Good. Going to check the patient's deep tendon reflexes. Right here.
Oh no, I don't like this part.
You don't like this part? I'm so sorry. I'm so sorry. Well, I'm practicing, so I don't always elicit a response, okay? Okay, we're going to track the DT back here. This is the triceps. You're going to have the patient, brace the patient's arm, have it hang loosely. This is a direct. It's not eliciting a response, but this is the way you do it. Brachial is here, and it is an indirect. You strike the hammer over your finger to see if you can elicit a response. Radial. Sorry. Radial. Patellar, finding the tendon. Oh, that one! Yay! I'm sorry.
That's okay.
So sorry, Monica. So sorry. And then attesting the Achilles. You want to find the Achilles tendon and come just medial to it. Good. Okay, and so I'm finished with the head to toe assessment. I did the anterior drawer, did the Murphy sign, the Rhine, Weber, Romberg, the transillumination. Transillumination is to check the sinuses. It's best done in a dark room. You're going to cup over the sinuses and illuminate from the skin to see whether or not there's illumination into the buccal mucosa. You open your mouth, please. Good, and he does have transillumination. Okay,